Great, thank you, Kevin. So yes, Kevin said, my name's Sheikh. I'm a neurosurgery trainee in the West Midlands, and I am also an academic fellow. So my research interest is in traumatic brain injury, and today I'm very pleased to present to you of some of the work that we're doing in sports concussion based at the University of Birmingham and also UHB. I noticed that there are some UHB colleagues on the call, and I'd be keen to catch up offline after this meeting as well. And also just to explore what the potential is for using multimodal data in sports concussion. So this is the outline of my talk. So I'll first explain what sports concussion is, because I am aware we have a variety of specialties in the call today. And from this, I'm going to talk about how we can use the data that we generate from when we do assessments of patients or athletes who have sports concussion. What can we do with that data to improve the care of people with sports concussion? So first, a definition. There are various debates about exactly what sports concussion is. And because of that, there was an international group that was formed called the Concussion in Sports Group. And they've had various iterations of definitions for what sports concussion is. The latest one, as you can see on the paper on the right side and on the text on the left, was done in October of 2022. And the key thing I wanted to highlight is that concussion doesn't necessarily have to result from a blow to the head. So it could be from an impact to the body or even neck, but that is causing a transmitted force to the brain and then resulting in potentially symptoms resulting from that. Now, concussion is thought of as a form of mild traumatic brain injury, and there's a spectrum of traumatic brain injury which goes from the mild, quote unquote, side all the way to severe, where you may need neurosurgical intervention and it's associated with a high mortality. Because concussion is a type of mild traumatic brain injury where people don't usually die from it or be severely disabled, it's often thought to be quite innocuous and something that people can just shake off and keep playing. But certainly in the last 10 to 20 years, there's been a step change about how we think about concussion and mild TBI in general. And this is from a lot of media attention that's been happening from like sports that have a lot of contact, for example, American football, rugby. And as you see on the right, there's been a lot of medical legal cases resulting from these kind of concussion events and the resulting development of things like chronic traumatic encephalopathy. And this is especially affected the rugby and the American football communities. And also even at the grassroots level, there was a case in 2011 of a 14-year-old boy who had what we think was a second impact syndrome from multiple concussions during a game and unfortunately passed away. So the key message I want to highlight from this slide is that concussion is not a benign disorder. Now, just very briefly, I'm going to talk to you about how we manage concussion. And this can maybe give you an idea of some of the problems that we have in current concussion care. So firstly, concussion is a clinical diagnosis, and it's made usually at the pitch side by a sports doctor or physiotherapist associated with the team. And there's various tools such as the head injury assessment or the sports concussion assessment tool. It's on 6th iteration at the moment. And there are a variety of symptoms that can result following a concussion. And it may seem like the most obvious thing is possibly a headache related to the point of impact. But as you can see from the image on the right, that there's also things like vestibular symptoms, ocular symptoms, cognitive symptoms that result from having a concussion. And at the moment, the way that we think is best to manage this is to manage those symptoms as much as possible. In line with this, there's been the development of return to play protocols from both at the grassroots level and professional level. So every sport you can think of does have a concussion protocol now. And that's because of the increasing awareness publicly, also from the policy side for concussion. The document that you see on the slide is from the UK Grassroots Committee on Sport and what to do with grassroots players, but there's things from the Football Association as well. And a return to play protocol usually lets players go back to competitive sport about 2 to 3 weeks following their concussion if they're progressing through various stages of post-concussion recovery. But where the symptoms might be prolonged or there may be a history of repetitive concussion, you might seek a specialist opinion from a sports concussion clinic. And this could be somewhere like in Birmingham. We have one at Queen Elizabeth Hospital, and also the Institute of Sports and Exercise Medicine and Health in London also has a NHS concussion clinic. And this is usually a multidisciplinary approach with concussion doctors, psychologists, physiotherapists, and occasionally we do scans on these patients. And this is Professor Belly, who some of you on the call may know. He's my supervisor, and he set up the Birmingham. We've been quite successful with running it. So I've hopefully given you a bit of an outline of how concussion is managed at the moment. But I have to admit that, like the image shows, it's a bit of a black box in terms of exactly what it is and how we manage it, what the prognosis for patients are. And in the process of making these slides, I thought about several questions that we still don't really know the answer to in sports concussion. And hopefully this will lead on to some of the ways that we can try and answer these questions using a data-driven approach. So as I mentioned, firstly, that we still diagnose concussion subjectively with clinical assessment tools, but really, is there an objective way of diagnosing a concussion? And also, how much impact really counts as a concussion? As I mentioned to you, you have head impacts, neck impacts, even body impacts that can officially cause concussion, but what level of G forces do you need to have a concussion? And can we predict which patients will have which concussion phenotype based on perhaps pre-existing characteristics or the type of concussion that they have? And in addition to that, who is at risk of having prolonged post-concussive symptoms? Is it a certain demographic group? Is it from having a certain number of concussions? And then following on from that, should we have a bar or a threshold for telling players to retire because of concussion? At the moment, it's very much all of these questions are really answered on a case-by-case basis, depending on the patient's clinical symptoms. But what would be really good is if we had some sort of objective way of helping these patients and getting the data. So I'm going to move on to hopefully talking about how we can try and solve this in a data-driven way. So I'm thinking that the way that we can possibly solve these questions is to first think about what data we have available to us, which could help us to answer the questions. So firstly, on the top left, you'll see from the athlete themselves, they may be having instruments or devices that can help give information to a clinician or researcher about possible concussion events or head impact events. So, for example, in rugby league and union, and recently in the Six Nations, they've introduced instrumented mouthguards, which have a built-in accelerometer, and they measure head impact events. And in American football, they've started to introduce instrumented headgears as well to track the same thing. There's several startup companies that have wearable sensors that, for example, with the one in the image, clips onto your helmet, for example, if you're an American football player, or to the side of your clothes when you're playing sports. So potentially we could, these are very good source of data to help us diagnose a concussion and get real-time data. In addition to this, we could think about the clinical assessments. So I mentioned at the start about the SCAT-6, and there's another one called the vestibular ocular motor scale. And this could also give some ideas as to the severity of symptoms and whether players are ready to go back to sports. Neuropsychologists have a role as well. They do a battery test checking cognitive function, and they can also help identify underlying mental health disorders, which we know are more common in the athletic population. And then at the bottom two are things that we've done quite a lot of in Birmingham with the Sports Concussion Clinic, where we've collected fluid-based biomarkers, which could be salivary, blood, urine, even cerebrospinal fluid in some cases, to look at any markers of traumatic brain injury and also concussion, and then try and see if there's a way of differentiating between them. Sort of like a lateral flow test for concussion. And the final thing is advanced neuroimaging. So in some of our cases in the sports concussion clinic, we do MRI with spectroscopy sequences, and sometimes we pick up abnormalities such as T2 hyperintensities. And what we really want to know is, does this actually have any relationship with the symptoms or return to play? Like, is this something that is relevant, or is it just a red herring? And that brings me on to the challenges that are potentially there when considering all this data. So firstly, there's a lot of data that's there, and we have to be quite clever in thinking about how we reduce the signal to noise ratio and get the data we actually want in a clean format. The second thing is about temporality. So if you see the diagram on the right, this is a biomarker called S100B, which is produced inside and outside the brain, but it's been used as a marker for traumatic brain injury. And actually in Scandinavia, they recommend using it to help decide if patients need CT scans in A&E for head injury. But this, the production of this biomarker is very dependent on exactly what time after injury we are sampling, and we have to think about how we can do this in a consistent way. Thirdly, the influence of pre-existing conditions. As I mentioned, mental health is something that's very it's much more prevalent in the athletic community versus the general population, and other medical problems like cardiovascular and respiratory problems. Could that have something that could influence the results that we have? For example, if we're managing biomarkers and we have athletes who have kidney problems, that could be something that's relevant. And the last thing is, what we're really trying to think about is what the long-term impact of concussions are. And I mentioned about chronic traumatic encephalopathy as something that's been linked to multiple concussions, especially in the American football and rugby community. So whenever we're thinking about having a data-driven approach, we have to think about what the actual long-term outcomes are of these cohorts and whether we can measure these different data points in a longitudinal fashion. So how can we use data to possibly help solve these problems? So I came across this blog from the Google AI research team, and I thought it was quite useful in describing 3 ways that they're thinking about integrating medical systems with their AI systems and large language models. So the first way we can think of is using something called a tool use, where you have an existing AI system, such as an image processor or a tool, and then you link that to an external large language model to help get the information that you need. So that could potentially be one approach. The second approach is something called model grafting, which is kind of a hybrid between the first and the third approaches, where you could have a domain-specific model, such as medical imaging, to work with an LLM and then give output on the other side. So as you see from the image that they showed from Google, they have a chest X-ray, which is going through the encoder and also the medical information part of the model, going to the LLM, and it comes as an output and can answer questions. And the holy grail is really having a general model that is basically an LLM in a box that you can just type in your query and find the answer. And this obviously is the most ideal thing. If I could have something that integrates all of the data that we can get from sports concussion, and it gives me an answer about the risk of prolonged concussion symptoms, or whether we can make a judgment about return to play at a specific date based on what the actual data shows, that's kind of the holy grail. But as you can imagine, this is also the most complex step. So really what I wanted to highlight from this talk was that there's multimodal data, and there are models that are getting better. And I'm sure you've all seen last week about the launch of GPT-4o from OpenAI, and how they've integrated multimodal data into more, I guess, consumer-facing tasks. But the innovation is definitely happening, and I'm hopeful that we can use it within concussion research and healthcare more broadly. And in order to do that, we have to really think about collaboration. So that's between healthcare professionals, basic scientists, data scientists, policy makers, sporting organizations, and of course the athletes as well, to try and develop something that's useful. And really one of the reasons why I wanted to give this talk is because I wanted to see if there's anyone interested in possibly exploring this further. So if I was kind of approaching it from the clinician side, if there are some data scientists who are involved or basic scientists, then it'd be good to maybe catch up offline after this meeting to see where we can take this. And I've come up with a possible name for this network, and I'm sure with ChatGPT I'll have a better name for it. But if you're interested, then please contact me using these details, and the slides will get sent through as well. So with that, thank you very much, and I'm happy to take questions.